Thank you, Dr. Dorsey. Now, Elizabeth Genovese will stand to talk about below-the-knee adjuncts for PAD treatment.
Wonderful. Thank you so much. So as all of us know, our patient population has an increasing prevalence of diabetes with nearly a quarter of people over the age of 65 suffering from diabetes. So what is this epidemic doing to our patient population? It's causing not only increasing rates of peripheral arterial disease, but a very specific type of arterial disease. A lot more calcium deposition, a lot more medial calcinosis, superficial and deep calcifications, increased risk of chronic kidney disease, all of which is giving us this very difficult distribution of below the knee and inframalleolar and outflow disease. And I have to agree with Dr. Guzman, although it's probably multifactorial, I think the distribution of our vascular occlusive disease below the belt is really kind of changing. And so a lot of this is resulting in difficulty having durable outcomes below the knee. So what is causing our difficulties and where is angioplasty failing? So when we have calcified disease below the knee, we can have difficulty crossing the lesion, we can have poor luminal gain, dissection, recoil, and if we scaffold, poor stent wall apposition. So when we think about crossing these lesions, there's a lot of different kind of tips and tricks that we have in our arsenal that we've kind of been using for years, right? Antegrade access, through and through wire access, balloon escalation with non-compliant balloons or micro balloons. You can do a pierce technique where you're hitting the calcium with your needle, or bad form where you're pulling your through and through as opposed to pushing it. But what's new and out there now that can help us with this? So one of the new technologies that we have that have recently come off the market is the Javelin, and this is from Shockwave, and as opposed to being a balloon-based IVL therapy, is a forward-facing catheter IVL that is right at the tip of the catheter that helps modify that plaque as you progress it forward to help kind of traverse those lesions that you haven't been able to traverse in the past. So this is a patient of mine that I used Javelin on. He was 53, end-stage renal disease. I'd angioed him twice to try to get a TMA to heal, and we just couldn't get him over the line. And where my arrow is where I couldn't get any catheter or wire. I can get a wire past it, but couldn't get any catheter or balloon past that. And so I want to show you what I was able to do with Javelin. And this is a nice technique where you kind of push some nice forward pressure. It shocks, and then it kind of gives for you. And so ultimately, I was able to take someone who, we're just trying to get him over that hump and get him some more pedal flow and get him that kind of additional technology to get us to heal. So we cross the lesion, but what is the bane of our existence below the knee? It's recoil. So as we know, about 35% of our tibials after we angioplast them will recoil if we look at them 15 minutes later. And ultimately what happens, we have abysmal outcomes with regards to POBA alone below the knee, with most people needing to be re-intervened on at 4 months. And you can see very low rates of primary patency and limb salvage over the course of a 3-year time period. So we want to get nice controlled luminal gain without dissection and recoil. So what are some cool new technologies that are out there that potentially help us with this? So the Serenator balloon is a non-compliant balloon that has little stipples of metal that kind of help create this serration in the vessel as you expand it in order to have kind of almost a controlled dissection, so you get nice luminal gain without recoil. And what the Prelude BTK demonstrated was that they have nice luminal gain with very low rates of recoil and dissection. Another type of technology that is out there that is looking at this is this reflow spur stent. So this is a balloon-mounted retrievable stent that has much larger spikes on it, and it's being utilized in order to really get nice vessel expansion without causing a dissection or recoil. And it will inflate into the elastic membrane and into the medial portion of the vessel. So the studies that have come out for this, we have the European study, the Deeper OUS, that came out and demonstrated about 40% vessel recoil, but primary patency rates of almost 80% at 12 months, and then freedom from TLR of 83% at 2 years with 100% limb salvage rate. Now, obviously, this is a cherry pick kind of patient population, but still very good results. Deeper Reveal actually just finished wrapping up, and so this is expected to give FDA approval here within the next couple of months. So this is a patient in part of our study of Deeper Reveal, and this was a guy, non-healing third toe wound, ultimately needed a TMA. So we began with this with gentle POBA, 2.5, 3, and you can see there's still some vessel irregularities, but we're to full inflation with the 3mm balloon. Ultimately, the stent is deployed, it's left up, you re-balloon it, and then you retrieve it to give some really nice luminal gain. Ultimately, he healed a TMA, and almost a year later, he's still patent. IVL obviously is something that we always have in our arsenal with regards to below-the-knee treatments. It's going to modify your deep and your superficial calcium. It's going to cause microfractures longitudinally, transversely, all to change the compliance of your calcium to really get nice vessel expansion without injuring that artery. The Disrupt BTK 2 trial recently was published demonstrating using the S4 balloon, which is a 40 millimeter balloon, to give nice results below the knee. You can see final levels of luminal gain of less than 30%, almost 100%. And you can see they're getting vessel wall apposition and luminal gain up to almost 2.5. So this has been demonstrated to be a very safe technology above the knee, and now this also demonstrates it's safe below the knee with minimal kinds of complications. The newest player on the block is their E8 catheter, which is really nice. It has a nicer crossing profile, hydrophilic tip. It now comes on a 150 shaft, so that way you can really get down to all the way to the ankle with this balloon, and it has a treatment length of 80. So often when we're dealing with these calcified tibials, we're not just using a 40 millimeter balloon. We're really wanting to modify the majority of that vessel. So now this is allowing us to do this in a quick manner and a much more effective manner. And we have a lot of different IVL players coming on the market. So Bolt was just acquired by Boston Scientific. FastWave is out there. Both of those are laser-based IVL as opposed to mechanical-based. And so this gives you unlimited amounts of shocks and the potential to even alternate where you want to distribute those shocks. And then Abbott has also come up with their own IVL that they're now trialing in the coronary space. So if we vessel prep, what do we want to do after we vessel prep? We have some off-label coronary use. We have very mixed results with paclitaxel below the knee, but really Limus is where it's at. So as opposed to being a cytotoxic agent, it is cytostatic, and it's led to reduced late lumen loss in the coronary literature. So we've, of course, put it on everything for below the knee. So we have Concept Medical, which has Magic Touch, which is one of the new DCBs that have coming out. They're starting to enroll in their below the knee trial, and they just presented their Sirona randomized control trial, which was above the knee, that showed it was not inferior to paclitaxel. And then, as we all know, the Esprit BTK stent, this is a bioabsorbable stent. It's made out of PLLA and is able to elute sirolimus over a 3-month period. So you have your drug elution over the 3-month period, and then you have your radial support over a 6-month period, and then you quickly lose that radial support, and that way you get that contractility back in your blood vessel. So you have the landmark trial that came out at 1 year that led to its FDA approval that demonstrates a 30% increase in primary patency, limb salvage, and duplex ultrasound, reduction of 50% stenosis at that 1-year mark. And then their 2-year data came out, which also demonstrates a consistent improvement in that primary composite endpoint at the 2-year mark. Again, demonstrating that this is a nice option for below the knee. There is some limitations. It's kind of a short stent, they are coming out with longer stents. But ultimately, this is where we're looking at as our final treatment. And so this is where a lot of companies are putting their research efforts. So we have more Limus DCBs that are coming to market in addition to Concept Medical. With regards to the bioabsorbable stents, you have a couple other companies that are having stage 3 and 4. So Riva has our version 2 coming out. R3 is about to go into trial as well with the 3rd version. Longer stents, a little bit more contractility. So it's a very exciting space, and I'm going to just take a second to plug the SVS course. So this is our CPVI course that's going to happen in the fall. So if anyone's interested in some hands-on advanced learning, it's a 2-day course that's going to happen in September. There's scholarships available for graduating trainees, and it's a really nice chance to kind of get some hands-on work and hear from a lot of our experts in the field. So thank you very much.